Hello, my name is Kerry Lyons, and I am the consultant Admiral nurse for Frailty for Dementia UK. So this is a nationwide post working within Dementia UK's core clinical services team. So today I'm going to give you a presentation on frailty, offering you an overview of identification and management. So after today's session, hopefully you will gain an understanding of what frailty and frailty syndromes are, what the vulnerability and risk factors of frailty are, what the symptoms and indicators for frailty are, the importance of identification and diagnosis of frailty, and what the management and monitoring strategies for frailty are. Now, today's session is only going to offer you a brief overview of the subject, but hopefully will give you a good introduction starting point to understanding frailty in more detail. So it's really important to know where we are, what concerns us, and what the possible opportunities are. What we do know is that dementia is characterised by a progressive deterioration of cognition and the ability to perform activities of daily living. Dementia is associated with a high burden of dependency and disability, and we know that this has a large emotional, economical, and psychological impact on families and society. We also know that more than 850,000 people are living with dementia in the UK today, and globally, approximately 50 million individuals have dementia. And this number is set to increase to around 152 million by 2050. So given that currently available pharmacological interventions can neither cure nor reverse dementia and can only offer limited symptomatic relief, there is an urgent need to start to identify potential modifiable risk factors that could prevent or slow development and progression of dementia as a disease. Research on dementia prevention, intervention and care identified that if 12 major risk factors were modified, 40% of dementias could be prevented or delayed. Physical frailty has been proposed as one of those risk factors. So several studies have reported that frailty is associated with cognitive impairments and a higher risk of dementia, which might be explained by frailty and dementia sharing many risk factors and clinical features, including age, inflammation, functional impairment, and multimorbidity. It is important to empower people living with frailty, as well as their family carers, to be able to understand the condition and make the most of available support and to plan effectively for their current and future care needs. National and local priorities are aiming to improve the identification of frailty and to be able to gain a better understanding of how to support people to live well with frailty. In England, support for older people living with frailty is identified as a priority in the NHS 5-year forward view and the next steps on the 5-year forward view. And having looked extensively at a number of publications, the accurate prevalence of dementia amidst frailty is an unclear national picture. And that is due to the fact that in some areas, progress around screening for frailty continues to be poor. What we do know is that dementia and frailty often accompany one another in older age, requiring complex care and tailored resources. So even though this is a recorded session, I want to make the presentation as interactive as possible. So throughout the session, I am going to ask you a series of questions for you to drop your answers into the chat box. I aim to leave enough time on each slide to enable you to offer a response before we move on to discussing the answer in more detail. So if you can open your chat box now, and let's start with our first question. So is this true or false? So looking at the current landscape, more people who are living with frailty are attending emergency departments, with over 4,000 admissions occurring daily for those people. So what do you think? So drop your answer in the comments box now. Is the statement true or false? Okay, so hopefully I've given you enough time to respond. So this statement is actually true. So older people living with frailty are more likely to be admitted and also more likely to be subject to a delayed transfer of care in hospital. And research and best practice is telling us that people with frailty could often have their needs met best in settings outside of acute care. And yes, there are over 4,000 admissions daily for people living with dementia. But we, as I've already mentioned, we suspect that this number is grossly underestimated due to poor practice nationally around identifying and screening for frailty. We also recognise that there are high costs associated with severe frailty, and this often brings over 4 times the cost of non-frailty. So what do you think are the national priorities and opportunities associated with frailty? So drop your answers in the comments box now. So the national priorities and opportunities. Okay, so hopefully I've given you enough time to respond. So the national opportunities are to embed screening to identify frailty within all persons over the age of 65. And if screened in as clinically frail, then to be able to follow this up with a comprehensive assessment of need with plans for intervention, for support and for monitoring. The second key thing that the national priorities are to take proactive approaches to prevent admission in the first place. And when a stressor event occurs, to be able to react urgently with a plan of support that prevents a long stay in hospital. And we're going to talk about stressor events shortly. And the third thing is to take home first and home based approaches to care. So we'll now walk through what frailty is, but before we do, just drop in any words into the comments box that spring to mind when I say the word frailty. So any words, connected words, any words that you would associate with frailty. Okay, so hopefully that's given you enough time to respond. So let's go with another question. So what do you think frailty is? Is it 1, 2, 3, 4, or 5? Or is it all of these? So is it number 1, an inevitable consequence of aging? Is it number 2, a state due to multiple long-term conditions? Is it 3, a condition in which the person becomes more fragile? Is it 4, a state associated with low energy, slow walking speed, or and poor strength? Or is it 5, a condition in which nothing can be done? So I'll just give you a couple of moments now to drop your answer into the comments box now. So 1, 2, 3, 4, or 5, or is it all of them? Okay, so hopefully that's give you enough time to respond. So the answer is the fourth statement. So we'll go through this in more detail. So the others are actually untrue. So frailty is not inevitable. Frailty can be interassociated with multiple long-term conditions, but can occur in the absence of these. Frailty is certainly amenable to treatment. This can often be referred to as modifiable stages of frailty. And unlike fragility, frailty is a specific syndrome with characteristic features and a rapidly expanding research base. So let's go through this in more detail in terms of the formal definition. So like I said, the fourth statement is correct. So frailty is low energy, slow walking speed, and reduced strength. Now, this sounds simple, but it's far from that. And I'm going to explain that in more detail over the coming slides. So what do you think, yes or no? So drop your answers in the comments box now. So is frailty classified as a long-term condition? So yes or no? So hopefully that's give you enough time to respond. So the answer is yes. So this is a textbook definition for frailty. So frailty is a long-term condition related to the aging process in which multiple body systems gradually lose their inbuilt reserves. It is now widely recognised as a state of reduced resilience and increased vulnerability, which results in some older people becoming more vulnerable to relatively minor changes in their circumstances, which can lead to a deterioration in their health and or their ability to live independently. So is the degree of mild and moderate frailty always static? So what do you think? So yes or no? Drop your answers in the comments box now. Okay, so hopefully I'll give you enough time to respond. So the answer is no. So it's really important to note that the degree of frailty in an individual is not always static. So it can naturally vary over time and can be made better or worse. So there is some evidence to suggest that the term frailty might not resonate with older people, may not resonate with their family members or their caregivers. However, frailty is a useful concept because it can help us to recognise and provide for the needs of people living with frailty as a long-term condition. How many people over the age of 85 do you think are living with some degree of frailty? So drop your percentage in the box now. So how many people over the age of 85 are living with some degree of frailty? Okay, so hopefully I'll give you enough time to respond now. So it's estimated that around 50% of people over the age of 85 are living with some degree of frailty. And some may experience frailty earlier in life, such as those living with long-term conditions or young onset dementia. But remember what we said about the screening practice for frailty identification. So therefore, we estimate that that percentage is probably grossly underestimated. Around 5 to 10% of people attending A&E departments are older and living with frailty, with more than 4,000 admissions occurring daily for falls, for minor infections and adverse reactions to medications. Patients over the age of 75 with frailty occupy around 20% of all inpatient adult bed days across England at any one time. And increasing numbers of people are at risk of developing frailty. So a person living with mild frailty has twice the mortality risk of a fit older person. How many stages of frailty are there? So drop your answers in the comments box now in a number. So how many stages of frailty? Hopefully that's given you enough time to respond now. So there are 3 stages of frailty. So there's mild, moderate and severe. So people living with frailty are less able to adapt to stress factors such as an acute illness, injury or changes in their environment, their personal or their social circumstances. And such changes are more likely to result in adverse health outcomes and a loss of overall independence. So the reasons why we're increasingly focusing on frailty is because we recognise that frailty is a condition that is associated with an increased risk of deterioration, and frail people are at far higher risk of an acute hospital admission or a care home admission. So what do you think? So yes or no? So drop your answers in the comments box now. Will frailty always be apparent? Okay, so hopefully that's give you enough time to respond. So the answer is no. It might need to be actively sought through an assessment. So it's important to recognise that frailty might not be apparent unless we actively seek it through an assessment. Many people with multiple long-term conditions will also have frailty, which might be overlooked if the focus is on the disease-based long-term condition and the treatment or the symptoms of that long-term condition. So why is it important to identify frailty? Well, older people living with frailty are at risk of dramatic deterioration in their physical and mental well-being after what can be apparent small event which challenges their health. So for example, an infection, a new medication, falls, constipation or urinary retention. However, it's important for us to be able to recognise that frailty might not be apparent unless we're actively seeking it through an assessment. And at the first time that we mention possible frailty to a family carer may be the very first time that they've heard about frailty as a long-term condition. Many people with multiple long-term conditions will also have frailty, which might be overlooked if the focus is on other disease-based long-term conditions that a person is experiencing. So other conditions may be fully recognised, but increasing and modifiable frailty go unrecognised and therefore not addressed. And there is evidence that in individuals with frailty, a person-centred, goal-orientated, comprehensive approach reduces poor outcomes and will certainly reduce unnecessary hospital admission. So when and how should frailty be identified? Well, any interaction between a person experiencing frailty and a health or social care professional should include an assessment which helps to identify if a person is experiencing frailty. The type of assessment will differ dependent on circumstances and on the location. But planning any intervention, such as a new medication, an admission to hospital, especially elective joint surgery, in an individual who has frailty without recognising it, certainly does risk significant harm to the person, as the presence of frailty may change the balance of benefit versus risk. So what do you think? So drop your answers in the box now. So how many frailty syndromes are there? So drop in a number into the box now. So hopefully I'll give you enough time to respond to that. So there are 5 frailty syndromes. So the 5 frailty syndromes are falls, immobility, delirium, incontinence, and the susceptibility to side effects of medication. The presence of one or more of these 5 frailty syndromes should raise a suspicion that the person has a position of overall frailty, and that the apparently simple presentation may mask a more serious underlying problem. So frailty identification and assessment is important to be able to recognise the characteristics of frailty. So the physical characteristics are weight loss, poor nutrition, hydration issues, fatigue, weakness, reduced physical activity, and a general slowing down. Being able to assess for frailty can aid in planning healthcare and support interventions that include both proactive and reactive approaching to managing a person's frailty. It's important to recognise that a person's degree of frailty can change, so it can go up or down over time. There are various frailty screening tools that are available, and these are often decided through local guidance and policy. A commonly used tool is that of the Clinical Frailty Scale, also known as the Rockwood Score. And this is a tool that we use at Dementia UK within our helplines and clinics Admiral nurse teams. So just to pick that commonly used tool, I'm going to cover the Clinical Frailty Scale, the Rockwood tool today, just to give you an overview of identifying frailty through this tool. So the Rockwood tool is a judgment-based tool to screen for frailty, to broadly stratify degrees of fitness and frailty. It's not a questionnaire, but a way to summarise information from a clinical encounter with a person in a context in which it might be useful to screen for and roughly quantify a person's overall health status. So the Clinical Frailty Score was developed to enable frailty to be identified and measured within outpatient settings, but more and more it's now being used in inpatient care to identify which patients would benefit from a comprehensive geriatric assessment. You can see from the image of the Clinical Frailty scale within the slide that a score of 5 is classed as mildly frail, 6 is moderately frail, and a score of 7 and upwards is indicating severe degrees of frailty. So you will see from the Rockwood scale that there are clear descriptors to help you identify the stage of frailty. But just to go through these in more detail, they are, so a score of 1 would indicate a person is very fit. So they're people that are very robust, they're active, they're energetic, and they're motivated. These people commonly exercise regularly and are amongst the fittest people for their age. A score of 2, the person would be considered as well, having no active disease symptoms, but are less fit than a score of 1. They'll often exercise, but it's more of a seasonal activity, less active in terms of frequency, so probably more occasional. A score of 3 is managing well, so people whose medical problems are well controlled but are not active beyond that of routine walking. A score of 4 is a person who is classified as vulnerable. So whilst not dependent on others for daily help, often their symptoms will limit their activities. So a common complaint is that they may describe themselves as being slowed up, or they may say that they're tired through the day. A score of 5 is mildly frail. So these people often have more evident slowing and need help with high order activities of daily living. So the instrumental activities of daily living. So such as organising their finances, transportation, heavy housework, medication administration. Typically, mild frailty progressively impairs a person's ability to shop independently, to walk independently, alongside independent meal preparation and housework. A score of 6 is your second category of frailty, so moderately frail. So people who need help with all outside activities, with keeping their house. They may also have problems with their stairs. They may need help with bathing, or might need minimal assistance with dressing. So they may need somebody on standby or queuing. A score of 7 is severe frailties. So that person will be completely dependent for personal care for whatever cause. So that could be physical or cognitive, physical and cognitive. Even so, they seem stable and are not at high risk of dying within a 6-month period. A score of 8 is very severely frail. So the person is completely dependent. They're approaching the end of their life. Typically, they could not recover from a minor illness. And a score of 9 is terminally ill. So that person will be approaching the end of their life. And this category applies to people with a life expectancy of less than 6 months. So the gold standard for the management of frailty in older people is to undertake what's called a comprehensive geriatric assessment, so a CGA, and that should be done once clinical frailty has been identified. The CGA should place the person and their family core and central to all assessment and subsequent planning around their frailty needs. The best evidence for CGA is based on identifying an appropriate patient through relevant screening tools, such as the Rockwood tool that we've talked about today. The CGA involves an holistic interdisciplinary assessment of a person, and it's been identified to improve outcomes. The completion of the CGA can be time consuming, so it may not be feasible for everyone with frailty in the community setting to undergo a full multidisciplinary review with a geriatrician, old age psychiatry, or a relevant frailty practitioner. However, all patients with frailty should have an holistic review based on the principles of the comprehensive assessment for older people. The CGA should include a review of current symptoms, of the person's current considerations around their underlying medical problems. And geriatric conditions such as functional impairment and dementia are common and frequently unrecognised or inadequately addressed in older people. So identifying geriatric conditions by performing a comprehensive geriatric assessment can help a clinician to manage these conditions and be able to prevent or delay complications. So conceptually, comprehensive geriatric assessment involves several processes of care that are shared between several providers and across various disciplines within the assessment team. So the CGA is a process of care comprising of several steps. Initially, a multidimensional holistic assessment of a person identified as living with frailty considers their health and well-being. And this then leads to the formulation of what's called a CSP, which is a care and support plan, to address issues that are of concern to the person and their family carers. Interventions are then arranged in support of the plan. Progress is reviewed and the original plan is reassessed at appropriate intervals, with the interventions reconsidered accordingly. So let's go through this in more detail. So I thought it might be helpful to very briefly summarise the components of the CGA, just for your information. Then you can start to think about your own assessments and incorporating elements of these within that assessment. So completion of a CGA should help gain an understanding of how the nature of factors contributing to degrees of frailty can provide an insight into the underlying causes of that person's frailty, and therefore offer some potential to guide current and future intervention alongside support. So the areas assessed and evaluated within CGA are within the current slide. So you would be looking at functional capacity. You'd be looking at a person's falls risk, their level of cognition, their mood, polypharmacy, social support, any financial concern, their goals of care, and their advanced care preferences. There are some additional components as well that should be considered, and that's nutrition and weight change, urinary continence, sexual function, the person's vision and hearing, dentition, their living situation, and the spirituality. So proportion of CGA is associated with screening for the 5 geriatric giants, which are iatrogenesis, which is an inadvertent and preventable induction of disease or complications by medical procedure or treatment. So polypharmacy would fall into that, so does elective surgery, just to pick 2 examples. The second is immobility. The third is instability. The fourth is incontinence. And the 5th is impaired cognition. The result of the CGA is an holistic review should be, as I stated earlier, so a personalised care and support plan that's developed, which focuses on the person's needs and their goals of care. The overall care rendered by CGA teams can be divided into 6 steps. So the first one is data gathering. The second, discussion amongst the team, increasingly including the patient and their caregiver as a member of that team. The third step is development with the patient and their caregiver of a treatment plan. The fourth step is implementation of the treatment plan. The 5th step is monitoring the response to the treatment plan. And the 6th is revising the treatment plan. Each of the steps is essential if the process is to be successful at achieving maximum health and functional benefits for the person living with frailty. So taking a person-centred approach to care, which recognises values and builds upon these individual, is essential in helping to achieve the best outcomes for people living with frailty. So the care and support plan should document a plan to optimise and maintain health and function for the person living with frailty, to illustrate an escalation plan, advising when the patient and their carer might need to seek further advice and support, to agree an urgent care plan, and to be able to forward plan in terms of the person's current and future care needs. And when appropriate, to be able to then undertake end of life planning and discussions around future care. Within an emergency, the presentation of an older person or a person experiencing frailty is not always straightforward. And frailty syndromes such as falls, delirium, and reduced mobility can certainly mask serious underlying problems. Prior knowledge that the person has frailty and that they have a care and support plan in place will help to aid decision making that's appropriate to the person and their needs. Where an older person or a person experienced it as being recognised as living with frailty, established systems and mechanisms should be in place to be able to share their health record information, including their care and support plan, between integrated care settings, between primary care, emergency services and secondary care, and social services. And these may be referred to as summary care record and will aid appropriate decision making. So hopefully this session has offered you a good introduction to starting to think about frailty identification and management. As the Dementia UK consultant Admiral nurse for frailty, I'm unable to take referrals from outside of our Dementia UK's internal core clinical service teams. And for this reason, I would also be unable to clinically advise and support you on any frailty questions or concerns you have regarding patients on your current caseload. Therefore, the best advice that I can offer you is for you to seek out local frailty services and support within your areas to be able to strengthen the support and signposting you can offer to your local families who are living with dementia alongside frailty. And there's some references and sources to further information for you. So I'll just pause on that slide if you want to take a photo. And the same here as well. Okay, so thank you for listening today. I hope you found the session helpful and informative.